Viral meningitis. Meningitis basics. Meningitis is an acute inflammation of the meningeal tissue surrounding the brain and spinal cord. Meningitis usually occurs in the fall, winter, or early spring, and is often secondary to viral respiratory disease. Older adults and persons who are debilitated are affected more frequently than the general population. College students living in dormitories and individuals living in institutions are also at a high risk for contracting meningitis. Types of meningitis. Viral meningitis is the most common and the least severe. Bacterial meningitis is considered a medical emergency. Untreated, the mortality rate is near 100%. Meningococcal disease is a life-threatening illness. It is a combination of meningitis and septicemia. Fungal meningitis causes severe infection but is very rare. It is not contagious and it spreads from inhaling fungal spores from the environment. Pneumococcal meningitis. Most cases occur in babies and children under 18 months of age. It is also possible to contract meningitis from parasites or through non-infectious means like cancers, lupus, certain drugs, head injuries, and brain surgery, or an existing condition of the skull or spine. Pathophysiology. There are disagreements on the long-term effects of viral meningitis on children. Some studies show that learning disabilities, neuromuscular impairments, and deafness are attributed to viral meningitis. However, it is believed that most of these cases must involve the CNS parenchyma, causing encephalitis and encephalomyelitis. Obstruction of arachnoid granulations by inflammatory debris can cause a rare complication, communicating hydrocephalus. The usual onset is within weeks of the original symptoms. Even less common is acute hydrocephalus, with onset within hours to days of original symptoms. Etiology. Viruses gain access to the CNS through two routes. The hematogenous route is the more common route of penetration for most viral pathogens. Neural route. Neural penetration is spread along the nerve root. It is usually limited to herpes virus and some enteral viruses. Host defenses. Local and systemic immune responses prevent viral inoculum from causing clinically significant infection. These defenses include skin barriers, mucosal barriers, and the blood-brain barrier. The virus replicates in the initial organ system, usually respiratory or gastrointestinal mucosa, from which it will then gain access to the bloodstream. Primary viremia introduces the virus to the liver, spleen, and lymph nodes. If the replication continues despite immunological defenses, secondary viremia occurs. This is thought to be the cause of virus seeding of the CNS. Rapid viral replication most likely plays a role in overcoming the host defenses. The mechanism of viral penetration into the CNS is poorly understood. The virus may cross the blood-brain barrier directly at the capillary endothelial level or through natural defects, such as the area of postremia and other sites that lack a blood-brain barrier. The inflammatory response is seen in the form of pleocytosis. Polymorphonuclear leukocytes lead the differential cell count in the first 24 to 48 hours. This is later followed by increasing numbers of monocytes and lymphocytes. The CFS lymphocytes have been recognized as T cells, although B cell immunity is also important in defending against some viruses. Evidence exists that some viruses gain access to the CNS by retrograde transport along nerve roots. The likely pathway for herpes simplex 1 encephalitis is via the olfactory or trigeminal nerve roots, with the virus being transported by the olfactory fibers to the basal frontal and anterior temporal lobes. Examples of modes of transmission in viral meningitis include the following. Enteroviruses, usually through the oral fecal route, but also sometimes through the respiratory route. Arboviruses via blood-sucking arthropods, usually mosquitoes. Lymphocytic choriomeningitis virus is through contact with rodents, usually hamsters, rats, mice, or their excreta.
The onset of viral meningitis can be sudden or develop 3 to 5 days after exposure and usually lasts between 7 to 10 days, and one can expect a full recovery. Viral and bacterial meningitis often have the same symptoms. Because of this, it is crucial to see a doctor as soon as possible. Bacterial meningitis can be very serious and can result in disability or death. The clinical manifestations of viral meningitis, most common in adults, are high fever, severe and persistent headache, nausea and vomiting, stiff neck, photophobia, which is an abnormal sensitivity to light, joint aches and pains, confusion and decreased level of consciousness, drowsiness, and seizures. Clinical manifestations in children are high fever, high-pitched cry, pale, blotchy skin color, not wanting to eat or reduce appetite, vomiting, fussy behavior, and difficulty waking. Clinical manifestations in infants are fever, irritability that is difficult to calm, decreased appetite and vomiting, and arching back. In the late stages of viral meningitis, babies may have a stiff body and bulging fontanelle. This is more common in bacterial meningitis, but can be seen in the late stages of viral meningitis. Clinical manifestations in older adults are usually mild. Older adults may have only a slight headache and fever. They may not feel well and have little energy. Lab test. Imaging such as X-rays and CT scans are taken of the head, chest, and sinuses to determine any swelling and inflammation. A lumbar puncture or spinal tap is performed for a definitive diagnosis of meningitis. Cerebrospinal fluid is collected through a lumbar puncture and is the most important test in determining the cause of meningitis. If meningitis is present, the cerebrospinal fluid often shows low glucose levels, an increase in white blood cells, and an increase in protein. Potential complications. Potential complications are secondary conditions and symptoms that are caused by viral meningitis, such as seizures, hydrocephalus, hearing loss, and weakness. Paralysis, cranial nerve palsy that impairs the ability to move the eyes, learning disabilities, behavior disorders, and speech delay. These have been reported more in infants and children. Infection may also last longer in a person who has a compromised immune system, such as someone with HIV, lupus, kidney disease, and elderly patients that have significant comorbidities. In many cases, the distinction between symptoms of viral meningitis and complications of viral meningitis are unclear and inconsistent.
Treatment for meningitis. In the event that an individual presents with possible meningitis, it is important to treat first, then investigate. This is because meningitis, particularly bacterial meningitis, has a high mortality and morbidity rate. As with the general treatment of any patient, it is important to first address the ABCs. If the patient has decreased level of consciousness and they need an airway, the patient may need to be intubated. Oxygen should be given to a patient who is hypoxic, and for circulation, IV fluids should be given. The primary treatment for bacterial meningitis is antibiotics. The primary treatment for viral meningitis is antiviral medications. Although some meningitis turns out not to be bacterial in origin, it is still important that the patient be started on antibiotics. It is important that the patient be started on antibiotics due to the high mortality and morbidity as mentioned previously. Untreated bacterial meningitis has a mortality rate near 100%. Antibiotic choices for bacterial meningitis can include third-generation cephalosporins, vancomycin, and, depending on the age group, ampicillin. It is important to check and see which medication is appropriate to use per patient. On the right side of the screen, you can see a chart that shows medications specific to a person's age or predisposing features. For patients with suspected bacterial meningitis, they are sometimes prescribed dexamethasone with the first dose of antibiotics. Dexamethasone has been evaluated as an adjunct therapy to aid in diminishing the rate of hearing loss and other neurological complications, as well as mortality in some patients who have bacterial meningitis. In most cases, there is no specific treatment for viral meningitis. Most people who get viral meningitis completely recover on their own within 7 to 10 days. However, people with meningitis caused by certain viruses, such as herpes simplex virus or influenza, may benefit from treatment with an antiviral medication. Antibiotics do not help viral infections, so they are not useful in the treatment of viral meningitis. In a patient with viral meningitis, doctors may prescribe non-steroidal anti-inflammatory steroids such as acetaminophen for fever and headaches. For meningitis caused by a type of herpes simplex virus, doctors may prescribe an antiviral medication such as acyclovir. The antiviral management of herpes simplex virus meningitis is controversial because some experts do not advocate for antiviral therapies unless encephalitis is present. This is because the condition is generally benign and self-limiting. For patients with cytomegalovirus meningitis, doctors generally prescribe ganciclovir or Foscarvet, both of which include induction and maintenance dosing. However, most of the viruses that cause meningitis have no treatments whatsoever.
Nursing diagnoses. Ineffective tissue perfusion related to increased intracranial pressure. Hyperthermia related to increased metabolic rate and neurological disease. Excess fluid volume related to increased intracranial pressure, syndrome of inappropriate secretion of antidiuretic hormone. Acute pain related to biological injury, cerebral edema. Risk for injury related to sensory dysfunction, seizure activity. Decreased intracranial adaptive capacity related to sustained increase in intracranial pressure of 10 to 15 milliliters of mercury. Risk for shock related to infection. Risk for aspiration related to seizure activity.